All right, good afternoon, everyone. My name is Kristin Long, and I am one of the endocrine surgeons here at the University of Wisconsin. And we're here today to do a Facebook Live presentation and try to answer some of your questions about thyroid cancer. September actually happens to be Thyroid Cancer Awareness Month, so this is pretty serendipitous timing. And hopefully we'll go through some of the nuances of the diagnosis, how we treat thyroid cancer, and answer a lot of the questions that are really common among patients with thyroid disease. So we'll get started with our first question, and feel free to send questions in. We'll try to answer as many of them as we can in the next 30 minutes or so and try to clear up some of the confusion about this disease.
All right, so our first question is, how is thyroid cancer diagnosed?
That's actually a really good question because thyroid cancer is something that is on the rise. It's now the 5th most common cancer in women and one of the fastest growing cancers in terms of diagnosis. And for many patients, you don't have any sort of symptoms. Commonly, somebody will feel a small lump or a nodule in their neck, but most frequently, the diagnosis of thyroid cancer is made on imaging or physical exam. The imaging typically is an ultrasound that we do to evaluate the thyroid. And that ultrasound will find evidence of nodules. Thyroid nodules in and of themselves are extremely common, but larger nodules, nodules with some concerning features, often need a biopsy. And then the biopsy is what tells us if there are abnormal or cancer cells in that thyroid nodule. And then we can go into some of the nuances of treatment. But I would say overwhelmingly the majority of patients either have no symptoms at all before their thyroid cancer diagnosis, or they feel a small lump or nodule in their neck, either on their own exam of their neck or on their primary care doctor's physical examination.
Are there different kinds of cancer, and how do I know what kind I have?
That's also a really good question. There are several different types of thyroid cancer. The overwhelming majority of thyroid cancer patients will have something called papillary thyroid cancer, and that's about 85% of the thyroid cancers that we see. There are several other subtypes, and those are much more rare. We generally think about dividing thyroid cancer into 2 broad categories. First, there is what we call the well-differentiated thyroid cancers. That's papillary thyroid cancer, follicular thyroid cancer, and Hürthle cell thyroid cancer. Those are all pretty easy to treat with surgery and another type of treatment that we'll talk about in a minute. And then the less differentiated types of thyroid cancer are what we call medullary thyroid cancer. And then probably the rarest type that we see is called anaplastic thyroid cancer. And that is the complete opposite end of the spectrum from papillary thyroid cancer. Most patients who have a diagnosis of papillary thyroid cancer can be treated very straightforwardly with surgery, with radioactive iodine, and then with thyroid hormone medication. Again, about 85% of the people we see have this type of thyroid cancer, and it can be really reassuring to have this discussion because this is a cancer that is extraordinarily well survived. We don't call it the good cancer. We actually hate that phrase, although some of you may have heard that. You know, any cancer diagnosis is scary and requires treatment and requires lifelong follow-up and effects on your life. But while we talk about papillary thyroid cancer, we sort of think about overall survival. And in general, we're fortunate because very few patients with papillary thyroid cancer will actually die from their disease. What we deal with is a high incidence of local recurrence, and that's usually in the lymph nodes. We'll talk a little bit about that more in just a few minutes.
How do I know what stage of cancer I have?
That relates a little bit back to the diagnosis. Now, the diagnosis is what we get from that biopsy that we talked about. When we have a thyroid nodule, it undergoes a needle biopsy, and our cytologists and pathologists can look at the cells obtained from that needle aspiration and tell us what kind of cells they see there. And that's how we usually get the diagnosis of papillary thyroid cancer. In order to truly know what stage of cancer you have, we need a very formal assessment of the thyroid gland, but also of the lymph nodes. And what we want to look at, particularly on ultrasound, are the lymph nodes that live right around the thyroid here in the central neck, and the lymph nodes out here in the lateral neck, to see if any of those are also involved or look abnormal. Overwhelmingly, thyroid cancer is stage 1. Thyroid cancer, particularly papillary, is basically the only cancer we have where age plays a role in the staging of the disease. So if you are under 55 years old, even if you have lymph node disease, even in your lateral neck, you're still stage 1. And so what that equates to is about 10-year 99.9% survival. People do extremely well in the long-term survival from this disease. If you're over 55, the staging is a little bit different, and some of that is because patients may often present with more involved disease. But I would say the overwhelming majority of patients that we see with papillary thyroid cancer are stage 1 or stage 2.
Do I need other tests?
Generally speaking, the most important test you can get when we're looking at thyroid cancer diagnosis is a high-quality ultrasound. Like we talked about before, that's what assesses the lymph nodes in your neck as well as the thyroid. Oftentimes there are other nodules in the thyroid. There may be other spots of thyroid cancer in that thyroid gland. And the critically important part is just assessing those lymph nodes, because that's what we want to treat at the time of surgery, is not only take out the thyroid gland, but also take out any abnormal lymph nodes. Now, if your surgeon or radiologist is doing an ultrasound and they do see an abnormal lymph node, either here in the central or in the lateral neck, they can do a biopsy of that lymph node as well. Same as what we do with a thyroid nodule. It's an ultrasound-guided biopsy where we use an ultrasound probe and a small needle to take a sample of the cells in that nodule, whether it's in the thyroid or in the lymph nodes. If we have evidence of cancer in those lymph nodes, then those also need to be removed at the time of surgery. So that's something we deal with as it comes about for each particular patient. Blood tests, we don't need a ton of blood tests. We do like to check your thyroid function. We also check a couple of tumor markers that are used in our surveillance of thyroid cancer. We don't have, for papillary thyroid cancer, we don't have a perfect tumor marker. What we use is a blood test called thyroglobulin, and that is something that's made by thyroid cells, not thyroid cancer cells specifically, but all thyroid cells. And so we use that as the best available tool we have right now to kind of monitor for surveillance down the road. Other than some basic preoperative blood work and potentially an EKG of your heart or a chest x-ray before a surgery, you really don't need any other tests prior to seeing your surgeon or talking about the diagnosis of thyroid cancer.
Can you just remove the nodule, or do you have to take the whole thyroid?
Okay, so that's a fabulous question. In general, the nodules that we see in the thyroid are actually buried within the thyroid tissue. So it's really hard to just think about shucking out a nodule. The analogy that I often give is that it's kind of like trying to take the pit outside of a peach without bruising up any of the surrounding peach tissue. And that's pretty hard to do. Sometimes we can take out just a portion of the thyroid. The thyroid is a butterfly-shaped organ that kind of sits here in the middle of your neck. And if you think about it, there's a nice little isthmus in the middle. So we can often divide the thyroid in half without causing too much trouble or bleeding or risk to surrounding structures. But as far as actually going in and sort of trying to scoop a nodule out like you would scoop a scoop of ice cream, can't really do that. We'll talk a little bit more about when we take out part of the thyroid versus all of the thyroid here in a few minutes, but that's a good question.
Is thyroid cancer hereditary, and do my family members need to be tested?
So the question is thyroid cancer hereditary? And there are some types that are hereditary. We see that most commonly with the more rare diagnosis of medullary thyroid cancer. That absolutely can run in families. There's a specific mutation that can be tested for it, and it pretty dramatically affects the way we treat that. Papillary thyroid cancer can also run in families, although we understand the genetics a little less well for that type of disease. Most thyroid cancer, most papillary thyroid cancer is sporadic and truly does just show up, on its own, new mutation or new diagnosis. If you have a strong family history, say if 3 of your immediate family members have had thyroid cancer, then that clinically gives us a diagnosis that this is a hereditary type of thyroid cancer. And at that point, we would recommend potentially screening or treating other family members.
My thyroid has always worked normally. Why do I have cancer?
This is probably the most common question that patients with thyroid cancer ask me, and that is, all these years I've had normal thyroid function tests. How on earth could I have this big cancer that now needs to be removed? And interestingly, the thyroid can still function totally normal as a hormone-producing gland and still have a nodule that's a cancer growing in it. The two can be completely separate. If you think of your thyroid gland having a small, sometimes 1 centimeter 1.5 centimeter nodule that represents a cancer, the entire rest of the thyroid can still function normally. So there's not a great screening test or way to test thyroid function as it's affected by thyroid cancer, if that makes sense. Most patients actually have completely normal thyroid function for many, many years.
Gina says, after my thyroid was removed, I have had shortness of breath. Is that normal?
Not typically, unless you're in that immediate post-operative period. Sometimes having had a surgery and being on a breathing machine for a short period of time can give you a little bit of shortness of breath. Sometimes some of the fatigue and the short-term recovery can lead to shortness of breath. But as a prolonged symptom after thyroid surgery, it's not that common. If it's something that's persistent or causing trouble getting your daily activities done, or walking from the car to the store, walking a city block, or up a flight of stairs, then there's possible other causes for that.
Do I need chemotherapy? What about radiation?
That's also a good question. Let's talk about just how we treat thyroid cancer in general. And the way I like to think of this is that it's a three-pronged approach. So when somebody has a diagnosis of thyroid cancer, overwhelmingly the first thing we tend to talk about is surgery. In the last 5 or 10 years, we've started looking at an option called active surveillance, which means observation. So even in the face of a small, under a centimeter, documented thyroid cancer, we know that thyroid cancer is so slow growing that we don't necessarily have to immediately take it out. That requires a lot of close surveillance and surgeons and endocrinologists that you trust and that are comfortable with this modality, because it's not right for everybody. Most commonly, nodules that we see are bigger than a centimeter, and in that case we recommend surgery. Surgery can either be a thyroid lobectomy, where we take out half of the thyroid and divide it in that middle part, that isthmus that we talked about, or it can be a total thyroidectomy. If the nodules that are cancerous are all on one side and smaller than 4 centimeters and have no other concerning features, or there's no concerning features for lymph node involvement, then we can talk about a thyroid lobectomy. And there are reasons to do that, particularly trying to save thyroid function and maybe keep you off of thyroid hormone down the line. However, if you have nodules on both sides of your thyroid gland, or if your nodule is bigger than 4 centimeters, or we think lymph nodes might be involved, we generally need to talk about a total thyroidectomy. And that's an operation to remove all of the visible thyroid tissue. The reason we do that is for our second prong in that treatment approach to thyroid cancer, and that is radioactive iodine. We don't use traditional chemotherapy or radiation like you think of for other cancers. What we do in thyroid cancer is we use the fact that almost 98% of your body's iodine is stored in the thyroid gland. It is a thyroid cell's favorite food. And after the thyroid has been removed, we take any stray thyroid cells that may be behind, whether a couple of cells left over from the gland or microscopic disease in the lymph nodes, because no matter how good we are as surgeons, we can't see every last cell. We just can't see at that level. And then we give you a pill that has radioactive iodine in it. And what that does is that goes to any stray thyroid cell, and I think of it sort of as a mop-up job to kill any stray cancer cells that might be left behind. Now, not everybody needs radioactive iodine. We use it a lot less frequently than we have in the past, but for certain cancers, large cancers, lymph node involvement, evidence of cancer growing out of the thyroid gland and into the surrounding muscle or tissue, or even the surrounding organs, those are patients that have a higher risk of thyroid cancer recurrence. And those patients do need to undergo treatment with radioactive iodine. The last prong of our treatment approach for thyroid cancer is what we call TSH suppression, and that is the thyroid hormone pill that you take. Once we take the thyroid gland out, you got to get thyroid hormone from somewhere. And so that's when patients go on thyroid hormone replacement pills. And we want you to be at a normal level of thyroid hormone, but for our thyroid cancer patients, we actually give you just a little bit extra thyroid hormone. We don't want to give you enough that you're clinically hyperthyroid, which is where you're jittery and your heart's racing and you feel hot all the time. But we want to give you enough so that if there's any stray thyroid cells that are left behind from either surgery or somehow they survived radioactive iodine, they can hang out in your neck as long as they're not growing or causing problems. And the way we do that is by suppressing them. We give you enough thyroid hormone that your brain never has to send out that signal, that TSH that we check, that stimulates a thyroid cell to grow. So that's really how we approach treating thyroid cancer. Surveillance involves checking some of those blood tests and ultrasounds as well to see if there's any evidence of a cancer recurrence. And as we kind of alluded to earlier, that's what we deal with most of the time in thyroid cancer, is not necessarily dying from your disease, but having a local recurrence and needing either additional surgery some years down the road or additional treatment with radioactive iodine.
If other family members have either hypothyroidism or hyperthyroidism or Graves', is that possibly linked to my papillary thyroid carcinoma?
So that's a tough question to answer, but it's possible. We know that we find incidental thyroid cancers in patients who undergo surgery for Graves' disease. Hypothyroidism, particularly Hashimoto's, which is the most common type of hypothyroidism in the United States, can be associated with development of thyroid cancer. But it's also possible that this thyroid disease is true, and unrelated. I would say that as a whole, we don't have a great linkage for that other than knowing that they can be related. They're not related in everybody, but I would say if you have a strong family history of thyroid disease, it's worth keeping an eye on your thyroid gland and maybe even a little closer surveillance than if you had nobody in your family that ever had thyroid disease.
How do you follow patients after treatment?
So after treatment, depending on what that treatment is initially, whether it's surgery or surgery plus radioactive iodine, we follow patients with two things, and we're looking for two things. We follow with ultrasound, which is incredibly important. High quality ultrasound is one of the best things that you can have as a thyroid cancer patient because it allows us to look for what we call structural evidence of disease, meaning is there a lymph node that looks abnormal, or is there a nodule in the thyroid bed that is concerning for a cancer recurrence. Maybe there were a few tiny cells of thyroid tissue that were left behind and they've grown into something that needs to be removed. So that's number one, is ultrasound. And we want to make sure, as we did with our initial thyroid cancer diagnosis where we looked at the gland but also at all of the lymph nodes in the central and the lateral neck, we want to make sure we're looking at that when we do our surveillance as well. And then the second thing we do is that thyroglobulin blood test. Now, it's not perfect as a tumor marker because it's not specific to thyroid cancer. But in theory, if your entire thyroid gland has been removed, the thyroglobulin level should be extremely low or even undetectable. And so we monitor that for intervals of about 6 months to a year for several years going forward to look for evidence of what we call biochemical evidence of disease. If that thyroglobulin starts to increase, then it means that there's thyroid tissue somewhere. It doesn't necessarily mean that it's thyroid cancer, but it means there are some thyroid cells that for whatever reason are growing. And that prompts us to keep a closer eye and look more in depth for any structural evidence of disease that we would treat with surgery as we continue to survey you. And we survey patients for many, many years because as slow growing as thyroid cancer is, we can have recurrences 10, 20, 30, 40 years down the line. And I would say that overall, we don't have a great answer for how long and how closely we need to follow patients. I usually follow all of my patients for about 5 years and then work in conjunction with an endocrinologist to determine how closely we need to follow after that.
Can the cancer come back?
So that's sort of what we were talking about. Can cancer come back? Yes, it can. It typically can come from even a stray single cell that was in a lymph node and maybe laid there dormant for years to decades, but for whatever reason starts to grow suddenly. And that's the 30% of patients that have a local recurrence. That's why we survey patients, and that's why we keep a close eye on people after surgery. So yes, it can come back. Most of the time it doesn't, but it certainly can.
I am over a year out from a total thyroidectomy and still have a very pronounced scar/shooting pain. What do you recommend, or is that normal?
So the scar itself continues to remodel for about a year after surgery. Oftentimes those little shooting pains that you feel, if they're right around just a total thyroidectomy scar, it's the little peripheral nerves in the skin edges, and that may or may not get better. If it's a lateral neck dissection, same thing, basically. It's still the skin nerves that bother people. What I would recommend is actually massaging the scar tissue. Of all the things that we've studied to help minimize scar tissue and minimize pain associated with that, it doesn't actually matter what you rub into it, whether it's vitamin E or Mederma or Scaraway, any of those products you can get over the counter. It's actually just the act of massaging that scar tissue and helping to break it up and soften it up that will help you feel better. If you're a year out and you're still concerned about it, it's certainly reasonable to talk to your surgeon. I give my patients the caveat that if in a year from surgery you're unhappy with your incision, either how it's healed, how it looks, or any problems that you're having, it's reasonable to discuss a scar revision.
I had my thyroid removed and gained 30 pounds. I have been thin all my life. My endo says, according to my labs, I am hyper, so why am I having such a hard time losing weight?
That's also a really hard question to answer, because that's the thing I think most patients are concerned about with thyroid hormone is I'm going to gain a massive amount of weight and it's going to be uncontrolled. In general, if your thyroid tests are within the normal range, most patients do not gain a tremendous amount of weight. Although that being said, what we know is that thyroid is intimately associated with metabolism. And when you take your native thyroid tissue out, even though your numbers might be in the normal range, your body may react a little bit differently to a synthetic thyroid hormone. Sometimes when you're hyperthyroid, we classically think of hyperthyroidism as being full of energy and super ramped up and excited and energetic all the time, but paradoxically I see a lot of patients that may be a little bit hyperthyroid who are very, very tired. And that is because if you think about it, to me at least, if you think about it at the cellular level, those cells are really excited and really turned on all the time, and you can't function like that indefinitely. So if you're too hyperthyroid, it may actually make you even more tired so that you're not even doing the things you would normally do in your daily life. And that's worth discussing closer with your endocrinologist or even also with your surgeon.
What are the risks of surgery?
Thyroid cancer surgery is incredibly well tolerated, but there's three main risks that we need to talk about. And I tell every patient that we're doing a surgery on to think about these three things. The first risk is bleeding, and that's a risk with any operation that we do. I mean, we have knives in our hands. But it's not so much that we lose a lot of blood during surgery. We ask our patients to stop blood thinners. We do everything we can to minimize blood loss during an operation, but what we worry about would be bleeding after surgery. If you think about it, this is a very small space, and even a small amount of blood here or a blood clot called a hematoma can push on your airway and make it hard to breathe. So that becomes a surgical emergency, and that's the main risk we worry about immediately after surgery. During surgery, there are two structures that we as the surgeon have to be very cognizant of and try not to injure. The first is the recurrent laryngeal nerve, and that is a tiny little nerve that runs right alongside your trachea behind the thyroid gland and inserts to innervate your vocal cords. So as we pull that thyroid gland up and over, we have to kind of scrape that nerve off the back of the thyroid and convince it that it's going to stay behind and work normally while the thyroid goes away. It's tiny. If we like food analogies, it's about the size of a little angel hair pasta. And so you can imagine it can get stretched pretty easily. The incidence of a permanent injury to that nerve should be about 1% to 2% in reality, but a slightly higher number of patients have what we call a traction injury, where it just gets stretched a little bit during the operation as we're pulling on that thyroid and bringing that gland out. That typically recovers on its own in about 6 to 8 weeks, but what it can translate to is some temporary voice problems and even swallowing problems for patients. Most of the time those are temporary, but they can be permanent. The last thing we think about are these tiny little glands called the parathyroids. And if you watched Dr. Schneider's event a couple of weeks ago, he talked a lot about the parathyroid glands. These are 4 tiny little glands. They're normally about the size of a grain of rice, and they live right around the corners of the thyroid. They're like smashed right up against the gland. And even though they live right next door, they have a totally separate job. And they control calcium regulation in your bloodstream. So it's the same concept. As we pull that thyroid up and over, we have to scrape those guys off the side and convince them they're going to stay behind. Most patients do really well and have no long-term problems with this, but if those parathyroid glands are either permanently damaged or inadvertently removed or never recover because their blood supply is quite small as well, then we could be dealing with problems of low calcium or hypoparathyroidism. Anywhere from 15 to 25% of patients may have some temporary hypoparathyroidism after surgery because, as careful as we are with those little guys, they often get a little bruised and battered and don't work great right after surgery. They're kind of angry at us for taking away the thyroid and they just shut down a little bit. If we give them enough time, they typically recover, but about 2 to 3% of patients are at risk of developing permanent hypoparathyroidism, where those guys either never recover or removed as part of the thyroid gland. And that means that you'd be taking lifelong calcium supplementation. you could live without your parathyroids, but the amount of calcium supplements you'd have to take would be quite cumbersome. So we do everything in our power as surgeons to try to save those guys.
All right, and our final question is, what should I ask my surgeon?
That's a fantastic question, and as a surgeon I can tell you, I think the most important thing you need to ask your surgeon is, how much thyroid surgery do they do? Thyroid cancer and thyroid surgery is something that's proven to have better outcomes with higher volume surgeons. So the more you do, the better you get at that type of surgery. These are tiny little delicate structures, and we want to make sure that we have as much experience as possible knowing where they are and how to protect them. Also, higher volume surgeons are more likely to recognize subtle signs of advanced disease, even lymph node involvement, and get every last bit of thyroid tissue out. We occasionally see patients who have had a total thyroidectomy and have obvious evidence of still some thyroid tissue in their neck. So having someone that is very comfortable with thyroid cancer is critical. You want to have somebody that does their own ultrasound, preferably. We use ultrasound as an extension of our physical exam. Not a patient that sees me gets by without me ultrasounding their neck myself and looking at the thyroid and the lymph nodes to see where I think there might be disease. I think it's also important to talk with your surgeon in great depth about the different treatment options. We alluded a little bit to active surveillance and to thyroid lobectomy and to total thyroidectomy. And somebody that's really well versed in thyroid cancer should be comfortable talking with you about all three of those options, who those are right for, and if that might be right for you. The last thing you always want to talk about is complications. Every surgeon will have complications, but you'd like to know their specific complication rates. I think as a rule, even the most conscientious, careful surgeon is going to have a complication sometimes, and you want somebody that will be forthright and tell you what the true risks are and the risks of that surgery in their hands. And that's really about it as far as the important questions. We want to know what's important to you. Every patient with thyroid cancer has different questions and concerns, and we're still working to understand the true impact that this has on patients' lives. So you ask us a lot of questions, we'll ask you a lot of questions as well. I think that's been an excellent overview of thyroid cancer. You guys have asked some fabulous questions. And the last thing I'll leave you with is that if you would like to schedule an appointment with any member of our team, we have 4 full-time endocrine surgeons who eat, sleep, and breathe thyroid cancer treatment. Feel free to call us. The number to reach anybody is at 608-242-2888. And we look forward to trying to answer your questions.